Last time we talked about someone that was clinically worsening, getting bad. They came from which mode's the best mode ever? It's the GOAT. PRVC, right? They went from PRVC, and they went probably to a pressure control mode because they're getting super sick. They're going to a disease process known as ARDS, right? They're getting really ill, and pips and plats are going up in that situation, and their football was falling over. So what football he's talking about? Yeah, the football was falling over. They were getting higher pressures, lower volumes, and we had some strategies we did for ARDS patients, right? And then now we're going to be optimistic today. We're going to talk about getting patients off the vent. So they're going back to PRVC, and they're going to go to a mode that's the best mode for weaning, which is pressure supports, right? We don't use SIMV or CPAP. That's not a recommended mode. Sometimes there's some fringe cases where you would use it, but pressure support is the mode that you'll be using. And colloquially here at Palmdale, people always say, put on CPAP, put on CPAP, put on CPAP. And you look at all three of those machines, they all say pressure support. It's like, oh, do you not understand the words coming out of my mouth? Right? So they are, yeah, it's pressure support is the mode that is understood to be utilized when you want to wean someone off the vent. Okay? So recap for ventilators, right? Air goes in, that's your tidal volume, and you can set that tidal volume. You set that tidal volume with which modes? With your tidal volume control modes, right? So your volume control modes are where you set the tidal volume. You say give 400 cc's or 450, and we know that our PRVC mode is one that is smart about it. It will say that, I guess, to understand you want 450, but I'm going to regulate that pressure. I'm going to give you volumes based on the pressure that the RT set, right? The RT says 35, it's only going to hit 35, volume up to 35. If the RT sets a pressure of 50, it can deliver volumes all the way to pressure of 50, which is worrisome because when you have high pressures, what does that lead to? High pressures in the chest leads to? It leads to barotrauma, and atelectatic trauma falls under that category, right? All right, so we got volume control modes, all right? When our pips and plats are going up and the football starts falling over, not football, but football starts falling over, that is then we're going to be setting a PIP, a peak inspiratory pressure that we don't want to go any higher than, right? And that's in a mode called pressure control mode, right? We're setting pressure control mode, and we're not letting the pressure get any higher than X, Y, or Z, whatever we set it to be, whether it be 25, like we were in rounds today, and the doc says don't go any higher than 25, but go ahead and get a target tidal volume of 400. So the RT's gonna go in there, they're gonna do their thing, right? They're gonna cast a few Harry Potter spells, right? Tidal volumeticus, and it's gonna be make sure they're going to then get to whatever pressure they need to get to achieve that 400. And if they start getting higher and higher pressures, then they might have to do some more finagling to get some better oxygenation. Okay, all right. So PIPs, plats, and ABGs look good, and there's all kinds of other stuff we can look at. Then we can put them into a spontaneous breathing mode or a spontaneous breathing trial. We're going to trial them on a mode where they're breathing on their own, right? Or a weaning mode of some sorts. All right, so that's the goal with ventilators, is to get them off, right? And we have what's called the ABCDF bundle, and that bundle it gets people off ventilators, it gets people off out of the ICU as well. So we encapsulate all those things to try to get patients off ventilators as soon as we can. Okay. All right, so our goals, again, are to support oxygenation and support ventilation. Ventilation is where you're changing the CO2 by adjusting the respiratory rate or the tidal volume. And you can fix oxygenation by changing what? Your PEEP or your FiO2. Those two things will change your PaO2. And your PaO2, again, correlates to your SpO2, right? And then, of course, we make sure that they are comfortable. We don't like put them asleep like surgery. We make them comfortable, right? We make sure that they are awake and alert and calm, right? Anxiety is taken care of, pains can take care of, agitation is taken care of, all the things that we can do with medications that we have at our disposal. Okay, and that's part of the ABCDF bundle is A, assessing pain, C, choosing the right sedation, right? D, assessing for delirium if they're getting agitated, and trying to fix those things. Okay. So yeah, so if you're getting worse though, right, we're not going to breathing trial modes, then we're getting in, right? Jesus is at the wheel, or we're going to go and we're going to pressure control. That's how we have to, fix the problem until we can get to a area where the volumes are not raising my pressures. And the reason why my volumes might be raising my pressures is because I have some kind of lung pathology going on, right? I have let's say a pneumothorax, or I have a pneumonia that's getting worse, or I have an effusion or edema that's getting worse. All these things are making it so that the pressure in the lungs is going up and I can't give more volumes. If I was on volume control mode of like 400 cc's, for a healthy person, that might not raise the pressures in the chest, but for an unhealthy person, it will. Okay, so we can control both of those variables. All right, here's a little summary of our modes here. Volume control mode, pressure control mode, or PRVC is a combination of both of those, and that's the one we want to deal with, right? So we talked about lung compliance and lung and PIPs, right? The pressure in the lungs and assessing the difference between the two, and that can tell you if it's an upper airway problem or a lower airway problem, right? So that's the idea behind our vent modes, right? So now we're going to get a little easier. We're going to talk about some of the weaning modes, and then we're going to talk about some complications of the ventilator in of itself when you're in long term, because sometimes people are in ARDS for 7 days, 14 days, 3 months even. And then we have to then at some point turn them around and get to a weaning mode, okay?
Respiratory, this is Greg. What's up?
Yeah, I'm in 284 with Mr. Smith. The ventilator's making some funny sounds.
Like what?
Like, I don't know, something like that. It's weird.
Can you put the phone up to it so I can hear?
It's not doing it anymore. I hit some buttons and it stopped.
What did you press?
I don't know, but the family is here and they're happy it stopped. I mean, it's good that it stopped, right?
I'm coming right up.
Oh, wait. Something's happening.
I'll be right there. Don't touch anything.
Maybe he needs some albuterol.
I'm almost there.
Oh my gosh, you did so great. Wonderful.
Such a great job. Thank you for calling that guy.
Greatest nurse ever.
All right, so we'll be able to know some of those numbers by the end of these lectures. All right, so SIMV and CPAP. So again, these are modes that have been phased out. We don't use these as much, but what is SIMV? It's synchronized intermittent mandatory ventilation. So they are breathing on their own, but it will deliver whatever breaths per minute you say. So usually it's like 8 to 10, somewhere in there. So they'll say SIMV of 8. We set the volume for those 8 breaths and PEEP of 5, right? And it will, it doesn't support the breaths in between, right? So you look at here's SIMV, here's our SIMV of 8 right here, and the breaths the patient takes are the breaths the patient takes, right? There's the breath they take, and you see a little tiny little volumes. They're probably not weanable yet if the volumes are on the poor side. But this has been phased out for a mode that we like, which on the next slide, which is pressure support. Okay, so it delivers set tidal volume breaths at a set rate, which is the mandatory piece. And then we have a rest rate that's low, it's like our backup rate to make sure they don't stop breathing altogether. But nowadays vents have apnea alarms and they can say, hey, your patient's not breathing, and after 20 seconds it'll switch them automatically from a weaning mode to a volume control mode or whatever they were on before. Okay. So your backup rate is no longer in favor. It is uncomfortable, right? Because you're breathing on your own. It's like, oh, 8 times a minute, it's coming. And you're just breathing on your own, so people don't like it. Okay. So then CPAP. So CPAP is, like we talked about with a non-invasive positive pressure ventilation when we talked about BiPAP and our BiPAP machine, which can deliver CPAP or BiPAP modes. It's exactly the same. So the patient is only getting, they have their inspiration, their expiration, right? There's our negative inspiratory force that we're used to seeing on a normal respiratory cycle. Beforehand, we were always blowing air into that patient with positive pressure ventilation. With CPAP, they are actually drawing that negative pressure. They're breathing on their own, right? There's no other support besides the CPAP, the continuous positive airway pressure. We're keeping the pressure in the chest at a certain level, whether it be 5, 8, 10, whatever they may need, right? So this patient's pressure is not 0, right? The pressure is probably like 5 or 10 or whatever, maybe 8, right? So all we're doing is supporting the pressure in the tubing itself, right? We're giving like CPAP of 8, right? So it's providing 8 positive pressure in the chest, so they have a little extra, support by breathing through that huge straw and the tubing attached to it, to the ventilator. So it's just a way to provide a little bit extra push, but they have to work pretty hard to do that still. Okay, it's not as easy as pressure support. Pressure support is a lot more easier mode, and patients like it, right? And if you're going to do this, it's like, well, put me on a T piece already, and this is a T piece right here. You can see the big T right there, and that's where they're just open to air. They're just like they're snorkeling, literally, right? So the T piece is where they just open the air, and some providers, older providers, are like, oh yeah, if they can pass on T piece, they can pass on anything. Right? You got this, bro. All right, so it's not, we come to find out that it's actually doesn't have the best outcomes. It's better to use pressure support ventilation. Okay, so just to reiterate our analogy here, here's a sys control where there's a driver in the seat, right? And we got pressure support, which is on the next slide where the patient's driving, right? And the ventilator is the engine. It'll do its stuff to kind of help it along. If you ever driven a car in the 90s without power steering, Have you done that? And it's like power steering fluid goes out. It's like, oh, I should get this checked because it's really ridiculous to kind of turn the wheel, right? That's kind of like almost like T-piecing it, right? It's like you're barely doing it, right? You're barely able to turn the wheel, right? And SIMV is like you're driving, but there's no driver on top of you, right? So you're trying to do your own thing, but then there's someone's delivering 8 breaths a minute. It's like you're driving along and it says, oh, left turn, no, not right now, right? So that's the idea of pressure support is our go-to mode when we want to wean someone off the ventilator. Okay, here's an example of a T-piece as well. They do humidify it because it is oxygen, but also it kind of helps with the process as well, a little more comforting. But again, T-piece is not exactly recommended. All right, so then another SBT, another mode we're doing for spontaneous breathing trials is pressure support ventilation. This is our go-to one, right? If PRVC was the goat of volume control, this is the one for weaning modes, right? This one has the best evidence, right? They've done all kinds of research on all kinds of different combinations of modes and patient populations and such, and this is the one that kind of wins out in the end, okay? So you might see it as, pressure support at 12 on the vent, +5, 40%, and how would you say this to someone to sound intelligent, right? You would say they're on a pressure support of 12 over 5, or pressure support of 12, PEEP of 5, and 40% FiO2. So basically they have 5 a PEEP at all times in their vent and their lungs, right? They don't let it go any less than 5. Sometimes they need more, but if they they need an oxygenation issue, but nothing less than 5. And then on top of that 5, whenever they take a breath, it's going to recognize that. It says, oh, you took a little breath there. It's a little negative inspiratory force. Once it detects that, it's going to then blow up to a certain pressure, right? So it's actually the pressure on top of the PEEP. So if it's 12 over 5, so oh, you took a breath, I'm going to add 12 pressure on top of that. I'm going to support that breath with 12 of pressure, and you should get a good tidal volume with that, right? Sometimes that pressure support's not enough, right? Sometimes that barely is enough pressure for that patient to take a breath because of their lung hemodynamics, and they may require even more pressure support of 14 or 16 or even 18, right? They require that extra support to get the volume that they need. Because when you're weaning a patient, you're always looking at a few things to see if they're ready, if they're passing this SBT, right? Passing this spontaneous breathing trial. So one of the things you look at is tidal volumes, right? The tidal volumes are 200, 250, 280. Those aren't great, right? We'd like to see 500, 800. Those are good beefy tidal volumes. So how do you know someone is like doing great? That's on a pressure support of 8, right? So 8 is great. That is the one that you say if they're passing on 8 over 5, right? That's perfect, right? They are ready to come off the ventilator, basically, right? But again, the decision to come off the ventilator is always the provider, the MD. It's their job to decide if they're ready to come off, because there's other things at work, right? We're looking at all the vitals and all the numbers and such. We report all that to the provider, and they're the ones that says, oh, well, let's actually give some steroids, or let's give some more Lasix today, or let's actually get dialysis done first, or let's get the rescue rate's a little bit too high. So they look at these other factors to see if it's time to come off or not. Okay, so yeah, pressure support of 8 over 5, that's your golden numbers for pressure support. That's the one you want to have when you're saying, oh, they're weaning great. That's if they're 8 over 5, that's perfect. If they say, oh, they're doing great, all the numbers are great, but you realize pressure support is 12 over 5, it's like they're not quite ready yet. So that's coming down from 12 to 10, right? And see how they do. Doing great, let's go down to 8. Okay, we're not going to go to 5 because 5 over 5 is 5, right? So that's going to be that's just CPAP, and we know that CPAP is not as good. Okay, so this is like BiPAP as well, where you set a high pressure and a low pressure, right? An IPAP over EPAP, but they can't get their wires straight. I guess they're crossed because BiPAP of 12 over 5 is like, oh, go to 12, come down to 5. Go to 12, come over 5. That's not what pressure support is. Pressure support is start at 5, go 12 higher. So really 12 over 5 in BiPAP terms for pressure support is 17 over 5. It's stupid. So that's just FYI, there is a tiny little difference there. Okay, so there is no backup rate. So if they stop breathing, they stop breathing. So do I have to keep an eye on them? Yeah, you do. But your ventilator has an automatic mode where it'll switch back over to a volume control mode, the mode they were on before, if it has an apnea alarm that's detected for however many seconds the RT sets, usually like 20 seconds. Okay, and again, I always have to pause and make sure I don't say pressure control ventilation. I might have said it, I don't know if I did or not, but pressure control ventilation is a sick patient. Pressure support ventilation is not a non-sick patient, a healthy patient, right? As far as ICU is concerned, right? A patient that's getting better is a patient on pressure support ventilation. Okay, so it detects them breathing, takes a little negative inspiratory force right there, a little dip in the line, and again, that little sensor can be adjusted by the RT, but the ventilator is going to detect it, and when it does, it's going to start blowing the pressure in the chest, and it's going to help them pull in a volume, because that's how physics works, right? Once you have flow and pressure, you start getting a volume developed. Okay, so, and there's some other things they can work as far as like ramping and such, but that's not really what we have to worry about right now. Our job is to know what is the number. Oh, you're on 8? That's super. That's super. Let's see how you do. And then we're going to look forward to see if they start failing or see if they start getting better, right? So do they pass the SPT trial or do they fail the SPT trial? So those are things that we assess and the RT assesses.
What's the range for pressure support? You said 8 is good, 12 is like...
Yeah, 8 is perfect, right? We don't go under 8/5, but if it's 10, 12, 14, that's more support.
When do you go back to pressure control ventilation?
So pressure control ventilation is you wouldn't go back to that unless there's some fringe cases where you would, like with pulmonary fibrosis and such, but usually you're going back to your volume control mode in the middle there, and then when they're ready again, you go back down to a weaning mode. Okay, and sometimes patients are obese or they have big ascites, they have pregnancy, they have these things that are kind of putting extra pressure in the chest, and they need pressure support at 10 or 12, right? So we just got to run that by the provider. It says, oh, there's 12/5. They're like, oh no, what are you doing? 12/5 is gross. You're like, well, but have you seen their belly, right? So and then they say, oh yeah, well that's perfect then. So 12/5, they did great. Okay, we can take the tube out. Okay, so there's a little bit of asterisk there, but 8/5 is great for 95% of patients. Well, in America, 66% of people are obese, so that might change. Okay.
When you say 8/5, you're talking about IPAP.
So you could think of it as IPAP. Think of 8/5 as the 8 being the IPAP, but it is true. It's 8 over in addition to the 5. Okay. Whereas in BiPAP terms, it's yes, go to 8, come down to 5. Go to 8, come down to 5. But in pressure support terms, it's start at 5, go 8 higher. Go back down to 5, start up 8 higher. Okay, so it'd be like 13/5, right? All right, so ventilator alarms. So we kind of touched base on this before, but we're going to recap the last bit of our our modes of ventilation. So when we look at alarms, we can categorize them as low alarms, high alarms. And when they're low alarms, that means that we delivered pressure into the chest, right? The volume, this ventilator is really smart. It delivers a certain volume into the chest or a certain pressure to reach a volume into the chest, and it has little sensors on the way back, right? The volume goes in and the pressure goes back, right? Why'd the purple go away? Okay, so the volume is being delivered and the volume comes back, right? So the volume does not come back, that's a low pressure alarm, right? Or it delivers the volume and there's like no resistance, like whoa, shoot, what happened here? That means that there's a break in the circuit, right? They're disconnected, they're either extubated, they have a cuff right here that is deflated, right? That cuff maintains the volumes. So when you go in and out, there shouldn't be that much of a leak, maybe like 10, 15% leak. But there shouldn't be a large leak when you're delivering a volume, right? That's one of the reasons for our ET tube cuff is to keep the volumes we deliver to be the volumes we deliver, right? Otherwise we deliver it, some of it escapes, and then when it comes back out, some of it escapes, right? So we want to make sure that those match up. Okay, so are they disconnected? Are they extubated? Are they talking to you, right? If you hear a patient starting gurgling and start making noises, that's a patient that doesn't have a cuff that's inflated. That's one clue, and if you look at the ventilator, you can see low pressure alarms, especially compared to what they had before. Okay, when you're weaning a patient, so you might have low alarms when you have like apnea, so they're not breathing, you're not going to have higher pressures because there's no volume, right? And then poor minute ventilation, so the tidal volume starts getting lower, the respiratory rate starts getting lower, that's going to start lowering your pressures. Okay, that you're measuring over time. Okay, and then high pressure. So we kind of talked about this a lot as far as your PIPs and your PLATs, and you're looking to see, is it a PIP problem or a PLAT problem, right? It is an upper airway problem or a lower airway problem. The PIP's going to be higher in both situations. When you have a situation on the upper airway or lower airway, your PIP's always going to be high, right? So we just got to figure out, was it a difficulty getting the volume into the patient initially, or was it difficulty getting the volume, to expand the lungs, right? Was it a compliance issue with the lungs expanding, right? And why would that be difficulty getting the lungs to expand? Why would that happen?
Like fibrosis.
They got fibrosis, they got scarred lungs, what else? They got like a pneumonia that's raging just on one side, probably not, but bilateral pneumonias for sure. They got bilateral pleural effusions. They got pulmonary edema. They have all these things in the way. They got ascites, obesity, that'll do it too. You're doing a bed bath, you set them down, and your ventilator says pressure limit reached, right? Because that's what the RT says. It says, let me know when the ventilator gets to 40 or 35 or 30, right? So all these things can cause high pressure alarms, and your plateau pressure will be high as well, right? So when you deliver that volume, it doesn't have trouble getting up top. It has trouble like expanding the lungs down in the bases. And how can we assess the plateau pressure? Yeah, inspiratory hold is the button that will let us know what the plateau pressure is. Okay, so the pips will be high because you can't get that volume in, right? But it's not because of the upper airways, because of the lower airways. So we hit the inspiratory hold button, and you can assess the difference. You can see if there's a tiny little difference right here between the plateau and the peak, or is it a big difference? If there's a tiny difference, it's a compliance issue. If it's a big difference, more than 10 points, it's an upper airway issue. And when you have an upper airway issue, what could that be? Blockage of some sort, good. They got a kink in the tube, they got mucus in the tube, they got an old crusty tube that's been there for 14 days, and they don't want to do tracheostomy, but they want to make grandma live longer. And it's like, no, we're waiting for family to come on Thursday, and it's like it's Friday. It's like, well, that's 6 days, right? So that could be a more and more crusty tube that we have to be able to manage, right? So there's secretions of the way, there could be mucus plugging, there could be these things in the upper airways that are causing problems. Laryngeal edema or bronchospasm, all these things are causing difficulty getting the volume initially into the tube, right? So your pips will be high because it's the upper airways. And like, let's say on the flip side with like pneumonias and ARDS and fibrosis, the pips will be high, but it's the lower airways that are the issue. Okay, so we can just do a quick inspiratory hold right here, and we can assess what the difference is, right? So is it a mechanical issue, or is it a pathological issue that's caused my pressures to be high? Is it something mechanical, like my ventilator is kinked, the tubing's kinked, the patient's biting, right? Their HME on the tubing, on the ventilator tubing itself is full of secretions, right? When you have really bad pulmonary edema, you'll see the pink frothy sputums come into the ET tube and into the tubing. So that's the reason why my pressures are high, because there's fluid in the way of my volume, right? The machine is just as smart as us. It's just saying, hey, I'm getting high pressures. What's going on down there? And it's your job to look to say, oh, look at that, all that secretions. Let's get RT to change that, okay? And then pathological issues will cause high pressures, right? And how do you assess that? You'd assess, the inspiratory hold to see which one it is, and then maybe get a chest x-ray to see if the pneumonia is getting worse, the edema is getting worse. We can maybe get diuretics to blow off some fluid. We might need to get a procedure done to pull off the fluid off the lungs, right? End-tidal CO2 could tell you if the CO2 starts going up and up and up, that means the volumes are better or worse, the tidal volumes. If my end-tidal CO2 is trending up. Yeah, your volumes are worse, meaning that they're getting lower and lower and lower, right? All right, so your patient's desaturating. What do? So first thing you think of is worst case scenario, which is dope, right? So dope is disconnect. My ventilator's alarming and it's disconnected. What do? Reattach it, right? That's the easiest thing to do. But sometimes it's displaced, and it might be the T-tubes come out a little bit. It's above the cords. That's why we want to call RT as well. We want to make sure they're helping assess the situation, right? The family's going to love them, as we knew in that I saw in the last video. But the RT can help assess the situation as well, right? And you can let them know when they come in the room, or you can say, hey, I got low tidal volumes, and I can hear them talking to me. That means that they're probably disconnected. They're probably the tube is displaced. Okay. O is obstruction of some sort, right? They're biting the tube. They need a bite block put in place. They have secretions. The tube is kinked. There's something going on. There's bronchospasm. All these things that we can think of that we can assess, right? We can listen to the stethoscope to see if they have upper airway stridor. Like I said, we can assess to see if they have bronchospasm happening. What else? How else can we see if someone has bronchospasm? End-tidal, right? End-tidal is going to give what kind of appearance? A little shark fin appearance. That'll tell you that you have a bronchospasm at work. And we can then, RT's there, it's like, or you can call them the phone and they're on their way and say, hey, go stop by the Pyxis and get me some, albuterol, right? I need some breathing treatments. All right, so displaced, there's an obstruction to the place, there's obstruction happening, they're agitated, they're biting, they got a crusty tube. P for pneumothorax. So that's a worst case scenario, right? The lungs have popped, and that's going to cause what to change in my my pressures that I'm measuring on the ventilator. Will they be high or low if I have a pneumothorax? It'll be high pressures, right? High pips or high plats, or both? It's kind of a trick question. It's going to be both, because when my plats are high, my pips are also high, because pips are always higher than plats, right? But if I'm blowing air into into two lungs, and a lung pops, I'm blowing air into one lung, right? The same volume. So obviously the pressure is going to go up, right? And that other lung cannot comply and expand, so that's a compliance issue. Therefore, my plateau pressures are going to be high. Okay, and a chest X-ray can help you find that out, right? So sometimes you can't figure it out. It wasn't just a simple disconnect. You suction them, and airway's clear, and your end tidal looks beautiful. It's like, well, let's get a chest X-ray to see what's going on. And you realize, oh, one of the lungs has collapsed, right? And equipment failure. So that means you didn't plug it into what kind of outlet? A red outlet, all right? That could be an issue. Sometimes the vents just give out, and they got switched out with another ventilator, and the other one's like, yeah, put me in, coach, right? So they'll got to switch out, right? So what else? So power out. There's an O2 disconnect. The O2 goes off. Someone hit the O2 gas shutoff valve, like a visitor came by and punched it, which happened once, right? So that's a problem, all right? So we want to make sure we have O2 flowing to our unit, all right? And they're stacking breaths. So that's the S can be on there as well. All right, they got their breath stacking. So that's a dangerous situation, because the pips and plats will go up, but also it can raise the pressure chest so much that they start getting hypotensive, right? And that can lead to a quick decompensation. Okay, so again, why would my ventilator alarms go off? I have an increased respiratory rate. There's a respiratory rate alarm on there as well. Say, hey, you're breathing fast, because the RT sets that and when they do their vent checks, say, let me know when they're breathing more than 30, right? And then when they're breathing more than 30, we give them a call, and they say, okay, I'm going to change it to 35 now, right? And then they say, why don't you, what, they're going to come out of the room, hey, do we got a sedation for this guy, right? So that's something we can do to help, okay? And then apnea alarms. So especially on which kind of modes would you get apnea alarms? On any weaning mode, it'll get you an apnea, maybe not SIMV, because it has that backup rate. But CPAP will do it. Will TPs do it? No, it's not connected to the vent. How's the vent going to know? Right? It doesn't have Bluetooth connection to the ET tube. Right? It's like, oh yeah, yep, pressure's low, right? Or they're not breathing. But on our pressure support modes, the apnea alarm could be going up. That could be one of the reasons why you're hearing alarms coming from the room, from the ventilator. All right, they got low volumes, right? Especially when you're on a weaning mode, it'll let you know. Or when your pressure getting high, it might be a good idea to know when your volumes are low. And then high pressure alarms we talked about, your pips or plats are high, and we're trying to figure out what the underlying cause is. Is it because of a new flash pulmonary edema, or is it because of a patient that has a worsening effusion on one side, right? Or pneumothorax, worst case scenario. And then low pressure alarms are due to what? Disconnect. That's the most, when I hear low pressure alarm, they don't sound different. There's kind of like medium and high vent alarms, but when I see the alarm that says low pressure, I'm first of all going to look at the patient, make sure that they're connected. Right? The other piece is everything's connected, but then you follow it down, and it's not connected to the ventilator. Right? There's two ports that you plug in to the ventilator, into the ventilator itself. Right? There's an inhalation exhalation port, so we can look to see if it's even connected. Right? Because that could be an issue.